Welcome everyone that's just joined. I'm just going to give us one more minute to let people join because we're expecting quite a few today. There's 45 joined already, but just give us one more minute and we'll let the final people who are finishing off 9 o'clock meetings and wanting to grab a quick cup of tea before they join us. In the meantime, do feel free to say hi in the chat and where you're from, so you can see what colleagues you've got on the call and make connections about with other people who are interested in ethical commissioning. So yeah, do say hi to each other in the chat, or we just give one more minute to let people join. And we've got a good spread. It's the great thing about digital webinars still, isn't it? That we can get a good spread all the way from Angus over to Ayrshire. You're all very welcome. Okay, well, I'll just get us started now. It looks like that's the sort of majority of quick joins. So my name's Diana Heckram. I'm the Associate Director in our Community Engagement Transformational Change here at Healthcare Improvement Scotland. And I'm delighted to be co-hosting this ethical commissioning webinar alongside Dee Fraser, who's our Chief Exec from IRIS, a really close and valued partner with Healthcare Improvement Scotland, and also a real expert in all things about commissioning. And I'll hand over to Dee to finish this introduction once I've just given you a quick peruse of what we're going to do today. But firstly, I'll do the dull stuff. Do feel free to put your cameras on if you want. Sometimes it's nice to see an audience when you're presenting to see how it's landing, but feel free to keep them off if that's your preference. We will be muting people during the presentations, obviously. But at the end, there'll be a question and answer session where if you want to, you can come in and ask your question yourself, and we'll be, Des McCart will be inviting people to do that. If not, Des will ask you a question for you. He's happy to do that as well. Please do use the chat function throughout the webinar, put your questions in and we'll get them picked up at the end. If it's easier to remember to type them in as you go, then please do that. If you have any technical issues, please use the chat, or you can use the mailbox that you'll have received with the email, and there is a team in the background there. And we've got a few of our team there, Lindsay, Ashley and Katie, Kirsty, who are in the background there to be able to help us. The email address is in the chat if you need anything in the meantime, or you've got any problems. So today we'll be taking you through some work on the work we've been doing around ethical commissioning, and that will take you through what it is, what the findings are from our research. Dee will be presenting the work that IRIS has done in particular on their research, and then we'll be having some conclusions about what it means for Healthcare Improvement Scotland and how it will support us in our quality improvement for health and social care in Scotland. And then, as I said, at the end, Des will host us in a poll and a question and answer. And I'm personally delighted to be doing this because before coming to work at Healthcare Improvement Scotland in this role, I spent a lengthy career in the voluntary sector, being commissioned, being in charge of commissioning across 3 nations for a national voluntary sector organisation, and have worked for 3 or 4. I've been on the board of the Scottish Council of Voluntary Organisations, where we spent many a discussion and development day discussing the challenges of being commissioned and the role of the independent sector in our work. So I joined Healthcare Improvement Scotland to bring that extensive experience of what it feels like to be on the other side of the public sector into Healthcare Improvement Scotland and our work in the integrated space. And I am deeply frustrated about that all the evidence and all the knowledge that we've gathered over the years about relational working and the importance of relational working, that there is still the tension and the push to drive away our relations, to drive away our closest partners, to to drive away our most valued colleagues in pursuit of efficiency. And I think the fact that you've joined the call today means that you either share that passion or are curious about that passion to understand how that commissioning relationship can deliver higher quality and more effective outcomes. With the financial austerity and challenges we face, there is a real risk to our partnership working as the cuts to services and the cuts to our funding mean that some of those most trusted relationships are vulnerable just now. And so hopefully through this work, we can find a way where we still maintain and balance that incredible relationship between us, between the public sector and our community, third sector, independent sector colleagues, so that the money that we do have available and the resources and assets we have available in this country can meet our vocational passions to serve the people of Scotland as best as we can, because that's why you've taken up this hour and a half for your time today to understand how to do that. So we're keen to give all the support, and through the presentation, hopefully you'll hear the insights, but also how we plan to support quality through making sure that commissioning is ethical. And we're being delighted to do that work. We've worked with a range of national third sector organisations from outside the box to IDIS, to CCPS and Scottish Care through our time, our colleagues as well in public service at the Care Inspectorate and in Public Health Scotland and Social Work Scotland and the SSSE, also real partners in this endeavour. And we connect very closely to our Scottish Government colleagues, particularly looking at on the back of Feely, which is really on the back of Christie, let's be honest, to say what we can do for a Scottish Learning and Improvement Framework, how we can bring commissioning into whatever future the National Care Service or not will bring us, that we make sure that ethical commissioning is part of our improvement narrative and a critical pillar of our improvement narrative as we go forward in Scotland. So on that note, Isdie is also a great colleague on both the working group for the Scottish Learning and Improvement Framework and the steering group of it. Delighted that Dee's been able to help us that. She was bid for one of the commissioned pieces of work which we commissioned from Blake Stevens and Iris around this work, and that she's here to talk to you today. So I'll hand over to you, Dee.
Grand, thanks Diana. And don't worry, it was a good piece of commissioning from his, so you can set that kind of aside. No, so we're really delighted to be invited along this morning. We were delighted to do this piece of work. And we're delighted to be deemed an expert in commissioning, but I think Diana's a little bit too polite to say a commissioning geek, which would be closer to the reality. So, as you know, my name's Dee and I work for IRIS, and our job is really to try and make social work and social care support work better for people, which sounds very simple, but everyone in this electronic room will know how difficult that is. Essentially, we are here to help the people that help the people to do their thing better. And again, we're doing that in a pretty difficult context. And when I was putting together my notes this morning, I was actually going to start with, my name is Dee and I'm feeling pretty anxious. Not about public speaking, because I totally love that. Sorry, whoever's doing the slides, you're going to have to cut me off if I'm talking too long. But maybe like me, you're waiting with some trepidation to hear Shona Robinson's fiscal update this afternoon against the sort of grey and stormy mood music of a deficit-driven UK administration. You may be anxious about health and social care support system as we see it. It seems to be falling into what academics like to call a polycrisis, where we're seeing this series of interconnected systems fall out very much of normal range, and these can lead to generating significant human harms through volatility, excessive constraint, unpredictability, and disruptiveness. So given all of that, why on earth should we care about ethical commissioning? Well, I mean, you obviously do because you're on this call, at least I hope so. But just bear with me for a moment as to why this might be an important factor in getting us out of the mess we have got ourselves, well, we haven't got ourselves into, the system has got us into. So I've been working in and around improvement, not the formal kind, but the informal kind, by which I mean trying to make things work better for the people we support for several years now. And commissioning has always really interested me. when I was a social worker and a social care worker as a practitioner, it was frankly a mystery. I could not figure out how we'd ended up with this seemingly random selection of organisations with different criteria and different ideas about what good looked like in my local area. But then I'd seen it now as a kind of invisible and overlooked practice, balancing really challenging things such as support, preferences, needs, data, ethics, politics, ambitions, and ideas of what a good life looks like, planning and shaping services against ever-decreasing resources, an almost impossible task, to be fair to commissioning colleagues on this call. But it does sit at the very heart of our system. At best, it can act as a great facilitator and steward. It can see and respond to complexity. It can draw people together. It can help them learn and ultimately radically improve our response to people in need. But more fundamentally, since I opened with something encouraging about polycrisis and storms, is could commissioning be one of our routes out of this problem, this interconnected and complex problem we are stuck in? So when I say truly ethical commissioning, by which I mean not just the ethical commissioning principles, but asking ourselves, are we doing the right thing rather than are we doing the wrong thing righter, is an absolutely critical driver for change, which is why I'm so interested in it and why it is actually definitely quite an exciting practice and function. When commissioners are driven by core ethic, so their values, their understanding of the limitations and indeed the harms of our system, their own experience or in their own imagination to think through what it is like to get support and what support should look like, they can take powerful values-driven action. And this includes, as Diana's already very clearly and well articulated, promoting a foundationally relational approach to commissioning that seeks to create foundations for great support to flourish, not simply monitor compliance, manage decline, and look at ever-reducing and dwindling budgets. But to be fair to the commissioners on the call, that's putting a lot of pressure on you as an individual function within a system and on a practice that is itself deeply and foundationally constrained. So what we really need to do, and I don't want to give any spoilers for either piece of research, is address our underpinning cross-system problems with power, with funding, with fragmentation, short-term decision-making, bureaucracy, and our liking for rhetoric over realistic action. Ethical commissioning could really fulfill its potential as one of the routes out of crisis. So I'm just going to close here by saying I'm absolutely delighted to see so many people who are also obsessed by ethical commissioning. I think that is a great start. And I really look forward to hearing your perspectives in the Q&A in the chat about how indeed we might use commissioning as a really radical lever for the change we want to see. And that's me.
Thanks, Dee. Thank you very much, Dan, as well. And welcome, everybody. My name's Des McCart. I'm part of this team. And for those of you who know me, working in commissioning for way too many years as well. So this is the agenda for today. A little bit about what is ethical commissioning, and as I say, having been in commissioning for such a long time, the language around commissioning has changed, but an awful lot of what sits behind it, I'm not sure how much it's changed, and I guess that's part of what we're going to pick out today. We've had trust-based commissioning, we've had collaborative commissioning, so a lot of things for those who have been around it have been similar, and I guess what we're trying to pull out, so what is this difference in terms of a focus on ethical commissioning? So I'll touch a wee bit on that. We will then hear the main bulk of what you want to hear today is the findings from both the Blake Stevenson's research, which looked at the wider environment of what it means to try and do ethical commissioning. It's not about pointing to this is good or bad practice, but what does it actually take? What does it feel like to try and do this? And then from Dee, from Iris, hearing about what's it look like in a specific area, especially one of the most challenging around drug and alcohol work. Something perhaps, again, where commissioning has been less obvious and that little bit different. So you'll hear that difference, bring it out in one of the most challenging areas of commissioning practice. As Diana said at the beginning, is that this work was really focused on preparing ourselves as what is it we need to do, and we're sharing this research because it won't just be for us to do, but in that fourth part you'll hear what we've kind of taken from what we've heard in the pieces of work, and offering some conclusions that we've come to in terms of what our focus will be, and then there'll be a chance after that for questions from the audience. And what I would say is to encourage you to put questions in as you go along. So if you want to hold until the end, that's fine. It's slightly easier for me to read the questions, but absolutely, if people want to come in, you can raise your hand and we'll do that as well. So that's not a problem as well. So as I say, I'm a senior program manager with HIS, with a focus on community engagement, transformational change. My focus has been commissioning and how it's collided with the world of self-directed sports. I've always had that interest on how do we change our commissioning practice to align with the person-centered agenda that's prevalent from SDS, from realistic medicine, and so many other things that sit slightly outside of health and social care in terms of community empowerment. So how does commissioning practice need to change in that space? We recognising the challenges that there is around it, that have already been called out in terms of funding, workforce, and just increasing demands on health and social care, more complex needs in terms of mental health, the drug and alcohol world, recognising that the challenges they face are certainly not staying the same. They're increasing on all sorts of aspects of it. So what we do have that clear direction of travel set out in legislation policy about integrated health and social care systems, that holistic support to people, close to home in a way that treats people and their carers as partners in decision making. So what does commissioning need to look like if that's what we're trying to achieve? And that's what's been called out, as Diana said, and both Christy and Feely, about shifting our practice and shifting our thinking, not just within commissioning more broadly, but also within the commissioning distinctly in this part of it. So what we wanted to do was to understand, so what's it like just now? And what you'll hear in the pieces of work really focuses on case studies. So it's not so much about the theory of it, but and the hearts and minds part of it. It's actually what's it like to do this. So what you'll hear is a lot of detail about 6 case studies in terms of Blake Stevenson and 3 in terms of Iris work, to be able to dig in and say, what's this like and what does it feel like for people trying to do this? What's, I wouldn't say easy, but what's possible, what's most challenging within that. So what I was going to do is just firstly go through the term ethical commissioning. What are we meaning by that? And as most of this audience will know, it's not got a definitive definition yet, but there are core elements to it. And just to go through these, just so we've got a kind of common sense of what the starting point is here. So person-led care and support, what does that mean? So the person should be the priority at all levels of commissioning and procurement process. They should have informed choice over the support they receive. Public services should work in an integrated and collaborative way to meet needs and be transparent about unmet needs. So that's shifting that focus primarily onto people, and that being the primary driver in our commissioning rather than possibly a secondary driver in terms of value for money in a more broad sense. Human rights-based approach. And again, these are terminologies which have been around for a long time. The guidance round about the procurement legislation 2016 Act is human rights based, and yet we're still struggling with some of what does it translate to. So reaffirming that people's ability to access to human rights should be at the forefront of the commissioning and procurement processes. Lived and living experience, again, could be just buzzwords. It's talked about a lot. So how do we genuinely put lived and living experience at the heart of this? Full involvement of people with lived experience. People should inform commissioning and procurement processes at every level, and to make sure support is designed for the people who will use it. Information should be accessible, governance should be clear and transparent. So really thinking through what that means by way of lived and living experience being front and centre there. Outcome focus, and again, language which has been around for quite a long time in this respect. Thinking, what do we mean by that? So commission and procurement practice should focus on support people to meet their outcomes and live a good life. Focus on what matters to the person. And one of the mantras that we've been adopting is that you can't deliver outcomes. It's not for services to deliver outcomes. That's for people to achieve with help of services. So what does practice look like? Commission practice look like to support and enable that environment? High quality care and support. Commission support should be of high quality, absolutely, and tailored to people's needs and choices. So that very bespoke aspect of options 1, 2, 3, and 4 within SDS, how are you giving people real choice on their decision making and their influence on that? Quality monitoring should be part of contract management. There should be good complaints procedures and access to advocacy support for all. Fair work practice. And I think within all of this, and this is how are we doing this within, as kind of Dee pointed out there, the very depressing environment in terms of finance. So how do we maintain fair work practice within that and not look for just cheap labour within it, and even suggestions of volunteering taking place of paid work? So how do we have real focus on fair work? So workforce should be recognised and valued for the important and highly skilled work that they carry out, and commission improvement should thus enable fair work. This includes enabling effective voice, collective bargaining, trade union representative, fair pay, fair terms and conditions, access to training and career progression opportunities. I'm not sure if we would recognise that quite as the landscape as things stand, but that's the way direction we should be moving in. Financial transparency, so sustainable pricing, commercial viability, recognising the business end of this if we really want all of the stuff in the left-hand side there about person-led and human rights-based, we need to work financially as well. Providers should have fair share of financial information, procurement, commissioning to allow for sustainable pricing. Financial information should also be shared within contract monitoring to mitigate against the risk of provider withdrawal and failure. And we've seen that in the marketplace, should we say. Shared accountability, so that whole idea of collaboration or co-production, commission procurement processes should support shared accountability between providers and commissioners, and that has long been a contention that we need to get to that parity. And then lastly, climate and circular economy, and definitely not least, because it's one of the major challenges that we are going to face. So commissioning and procurement processes should support Scotland's transition to net zero emissions by 2045 with climate friendly approaches. And this isn't a secondary and nice to do, it's something which is also fundamental within that. So that's hopefully gives people a sense of when we're talking about ethical commissioning, what we mean by that. And I'm going to pass over to Claire, who's going to take us through the findings from the first piece of work.
Yeah. Thank you, Des. I'm Claire Hammond. I'm a Senior Strategic Planning Advisor within the Systems Transformational Change Unit at Healthcare Improvement Scotland, and I've been working with Des on these pieces of commissioned research. I'm going to walk you through the findings from Blake Stevenson, who were unable to be here today to kind of present it. The research for spec for Blake Stevenson was to have them look at some examples of where commissioning practices have been changing in 5 different HSCP areas. So it was a deep dive case study based research, so it isn't a Scotland-wide analysis, but what it was doing was helping to explore what it's like to try and do these changes in commissioning practices through the case study approach. In particular, we weren't looking for good practice examples, we were just looking for practice examples. We were looking for the realities of trying to make some of the principles of ethical commissioning work within our current landscape, and the types of things that they found worked really well or didn't work well, and them trying to achieve that. So the 5 case study areas that were chosen was around adult care home framework in Falkirk, collaborative commissioning for care at home in Scottish Borders, adults with disabilities and mental health needs within West Dunbartonshire, care at home micro providers in South Ayrshire, and mental health and wellbeing within Edinburgh. So what I'm going to do is just run you very quickly through the key features of each of those case studies. We don't have time today to go into the kind of nitty-gritty of what it was that they learnt throughout that way, but I do encourage you to have a look at each of those case studies in the Blake Stevenson report, and then we'll pull out those findings and look at them across the both research pieces later on today. So the Falkirk HSCP, so what they wanted to do was to explore the adult care home placements for under 65s, and they wanted to shift away from the current competitive tendering process in order to develop a strategy and a framework collaboratively with providers and across the HSCP. They made a deliberate choice to do some upfront investment and stakeholder engagement in order to build those strong, trusting relationships that are needed to underpin discussions around commissioning and procurement. They also made an upfront investment and engagement with people and families, and they engaged with staff both within the HSCP and across the provider organisations. And the mechanism that they used within the current procurement legislation was around the light touch regime, so that they worked out how they could better utilise those mechanisms. They attributed their success to very specific and detailed knowledge of commissioning and procurement held within the team, and that there was also a persistence amongst the staff team to drive that change. And they also made sure that they were building relationships across the HSCP, including with legal and with finance, in order to be able to all arrive at a similar interpretation and understanding of what it means that what they were trying to do, and what terms like value for money and price quality trade-offs actually meant in those contexts. The next one we looked at was in Scottish Borders. Now, they recently appointed a chief officer around strategic commissioning and performance, and what their task was to set up an overarching framework that guides all of their commissioning. So across children and adult social work, across mental health, learning disability, primary care and housing. And they brought that together with staff from those areas, and finance and procurement and QI, in order to build an overarching framework that helps to guide their commissioning across the board. And in order to do that, they established a board within the HSCP that would make those commissioning decisions, that had representatives from across those, in order to reduce the number of siloed decision making that was happening in commissioning under each of those segments. What they looked at first was to be able to use that group and to use that structure to do some collaborative commissioning around care at home and that engagement with providers in order to be able to build that framework. They attributed their success to some really detailed and specific knowledge around commissioning and the operational realities of making things work on each side of the equation. They invested PMO support, program management support, to ensure that they were able to gain and maintain traction. And they worked hard to really build that appetite for change as they went, seeing that that was a continual process that they needed to do throughout it. The next one was around West Dunbartonshire, and similar to Scottish Borders, they'd recently appointed a contracts commissioning and quality manager who was responsible for commissioning across the wide range of areas within the HSCPs, and specifically with a remit around self-directed support as well. The first one that they decided to look at was how they wanted to recommission services for adults with disabilities and mental health needs. And because they were working in an environment where there were a really limited range of providers and services available for them to commission. They spent some time across the HSCP and with providers and other stakeholders to really understand what the current challenges that were happening, and they spent a lot of time engaging with finance to be able to explore that understanding of value for money in the context of self-directed support, where actually a more expensive unit isn't necessarily not value for money, given that it's around people's choice of what they choose and how they choose it. And they also spent a lot of time developing in the upfront development of relationships with providers and HSCP colleagues. The next one was Edinburgh HSCP, and this is around their Thrive activity, which is a long-standing piece of work that they've been working on. So they started this process in 2016. And what they wanted to do was use a public social partnership in order to be able to procure, commission, engage and support mental health and wellbeing across Edinburgh. They started with a strategic level PSP, so public social partnership, that really set the tone amongst the public and third and independent sector organisations about what they were here for, what they were trying to do and what the values were that they were going to build that relationship on. And that acted as the foundation some years later for an operational level public social partnership. And that focused on the co-design of a service model in Edinburgh for mental health and wellbeing in the community. And that's where they developed their Thrive Welcome teams and their Thrive Collective, if people have heard of those. And what they were was a move towards consortium services clustered both geographically and then some that were cross-city on specific themes. They offered 5-year contracts by default with extension opportunities built within them, and they spent a lot of time throughout the years building a psychologically safe space. And one of the first things they did around that was to really openly acknowledge the power imbalances that were likely to happen within the room, and to be really clear up front about what was and wasn't able to be done about some of those decision-making balances, so that way people were all under the same impression about what was possible within that environment. The last case study that was looked at was around South Ayrshire. Now, South Ayrshire were responding to an environment with care at home contracts being handed back. There's a large gap in the provision where the current workforce and the current providers are unable to meet that demand. And so in South Ayrshire, they developed a group, the CAYR group, that was the HSCP, the council, the third sector interface, and 2 provider-related organisations. And they were specifically tasked with assessing the viability of using micro providers within their care at home. And that was to address that shortage, to see whether they could increase their workforce in a different way. And there are similar models in Scotland and in the wider UK that they were using to inspire that development. They attributed their success to being able to build that local and national partner buy-in right from the very offset in the way that they set it up. They got specific funding from the Integrated Joint Board in order to be able to do some really practical things like supporting individuals to set themselves up as micro providers and provide the infrastructure required for them to continue to operate. But one of the key things that they discussed was that actually this model didn't compete with the existing provision and wasn't a threat to the existing providers, because it was filling a very specific niche in a market where demand was outstripping supply. So we asked Blake Stevenson to identify the key drivers that they felt from those case studies were acting as barriers to ethical commissioning within our current structures. And you can read more about those in detail in their report, but I just wanted to pick up on a couple of them. The first is around the infrastructure around the commissioning profession, and that actually the structure of the teams and the roles that commissioners play across Scotland varies significantly, with many of them juggling multiple responsibilities that can make it really hard to dedicate the time required to see change. They also identified that the commissioning profession needs greater recognition and development as a specific profession that we need and critical. And this echoes a lot of the other findings around this area. Another one around capacity and resource constraints was that actually being able to have sufficient commissioning and procurement skill sets within the organisations was really vital in order to be able to drive that change. They also picked up a range of cultural and historical factors that drove quite a risk-averse culture within parts of the organisations, and that those were often based on assumptions or misunderstandings or an adherence to well-established and commonly accepted approaches. And the last one that I'll cover is around the competitive commissioning environment. So we know that from the research that there are tensions within the current competitive structures that we've set up and the principles of ethical commissioning. And in a context where supply doesn't outstrip demand, we need to reflect on that role of competition. We also asked Blake Stevenson to raise with us a range of areas that we think really need to challenge us and we need to be challenged to answer the questions around. And these are the areas that they came up with. How do we actually invest in ethical commissioning? It was clear from the results that you don't get this change without the appropriate investment in relationships and skills and time taken to do the processes the collaborative way. How do we create the right conditions? So often these cases were demonstrated a particular strength in leadership or a particular persistence in the way that the staff were operating. How do we create that excitement and that skill and that ambition in areas where that doesn't already exist? How do we use existing levers, the presence of established ways of doing things that actually aren't necessarily the tight bounds that we have to operate in within legislation and policy? So how do we widen the use of those existing levers? How do we provide financial stability? I mean, a core tenet to that is around the stretched services and being able to afford a really good quality workforce that we pay fairly. And how do we encourage locally suitable solutions? It was clear from the research that even where national mechanisms were adopted, there was a lot of work that needed to go in locally to make them fit for purpose and adapt them for the local context. And how do we foster that innovation, that creativity, and that passion that's required to often push changes that feel like they're running against the way that the stream of the system is pushing us? And how do we create that cohesive commissioning profession where we've got really good CPD and commission structures for a lot of clinical roles within health and social care, and even within some of the other professions around social work and things like that. But commissioning falls within the same category as a large number of the other professions we really need in health and social care. And how do we create that where there isn't the clear clinical pathways of CPD that we have in other areas? That is the findings of the Blake Stevenson, and what we'll do is we'll pick up the key themes of that within the next section after Iris's, but I'll hand over to Dee now, who is going to run you through the findings from the Iris research, which were focused on drug and alcohol services specifically.
That's great, thanks Claire. And I'm hoping this isn't a metaphor for joint working between organisations, but my take control button has disappeared and I'm not allowed to post anything in the chat. So could I ask a colleague from his, could you pop my slides on for me? That would be great. Everything's greyed out, I'm obviously banned. Thank you, Ashley, appreciated. See, you can always find a workaround in public service, we're fine. Great. Okay, so just again, piece of work we did with for our colleagues in his, it was myself and my colleague Louise, who unfortunately can't be here today. We looked particularly at ethical commissioning and how it works and how it has transferred or works within drugs and alcohol services. And some of the things we found very much echo what Blake Stevenson found in their really, really excellent kind of review of practice as is, as opposed to practice as we hope it to be, which is extremely useful. And some of them are actually quite different and related to the drugs and alcohol context. Could I have my next slide, please? So just a very quick outline about the study so that you can weigh the findings appropriately. This was a very, very small scale study. It's very exploratory and indicative, and it broke into three classic stages. We did a review of the literature. As you can imagine, there's not a lot of literature about ethical commissioning as yet because it's a comparatively new concept, but we looked at commissioning, we also looked at the ADP context, and we also looked at alcohol and drug partnerships plans to see what the kind of strategic environment was for this area. We then did some semi-structured interviewing focused on breadth. So that was talking to providers of support, organisations that represent people with lived and living experience, ADP coordinators, people from strategic planning, and some policymakers. And thanks to you all, because I know some of you are on this call. And then we did 3 case studies in Clackmannanshire and Stirling, North Lanarkshire, and Perth and Kinross. My next slide, please. So a little bit about the context, and again, there'll be people on this call who are really expert in ADP. You can drink your coffee, and those who are expert in commissioning, you can drink your coffee in the next slide. There are 31 ADPs. They lead the development and delivery of local whole system strategies aimed at reducing use of and harm from alcohol and drugs in their areas. So a very, very broad and ambitious remit. They are multidisciplinary, they're non-statutory partnerships, so they have an interesting kind of positional authority within what is still quite a hierarchical system, and are cross-sectoral. It's a very complex policy environment with a highly centralised vision, quite a lot of directive policy making, and quite politicised decision making throughout the system, from ministerial through to on the ground decision making, with quite a highly targeted and fragmented funding situation and a standards and output driven aspects to how the kind of system is organised. My next slide. So as a context in which local commissioning is already substantially shaped by centralised policy drivers and targeted funding. So this is, I would say, a slightly contrast to social care commissioning, which, despite its masses of challenges, which I'm not denying, has, I think, a higher degree of freedom to respond to what people need and want in their local area. The commissioning context is also made more complex by the ambiguous position of ADPs in terms of authority, which will recur through the research, and a very high variation in how ADPs and ADP coordinators view themselves as commissioners. Some of them don't see themselves as commissioners at all. Some of them are commissioners, but probably wouldn't articulate it that way, and others really firmly take on that role. And this is really seen in the variation in ADP plans, which we had a look at during the research, which tells us something important about how much the system sees itself as a commissioner. And my next slide, please. And I think the core question that emerged from the research for us that we didn't really expect was, what does it mean to be an ethical commissioner? And is it actually possible to be an ethical commissioner? So common across all respondents to the study was a real commitment to making the system better for people, a pretty clear-eyed understanding of the limitations of the operating context, and pretty pragmatic approach to broadly ethical practice in commissioning and the application of the principles where possible. But they also identified in a sort of recurring way, one, that their ethical kind of centre came from their values and their lived experience, and also that a fundamentally ethical approach to commissioning can't really be delivered for ADPs without radical change to the operating environment for these organisations, these groups. Sorry, excuse me. Next slide, please. So, related to this was how people viewed themselves within ADPs. Did they even see themselves as commissioners? So during our conversations across the sector, and in particularly the case studies, we saw that ADP commissioners sort of fell into 5 categories. So this ranged from the sort of traditional commissioner that we would recognise from a lot of the literature on commissioning. This is quite a focus really on the procurement aspects, a focus on process fairness, coherence, contract compliance, and you know, really kind of trying to do the current system well. We also saw ADPs who essentially saw commissioning as not their role. So commissioning was fully outsourced either to the HSCP or the local authority, very much in the way that procurement is. And they really focused on planning and did not see commissioning as integral to that. This was the most criticised model for providers, as they find that in this area, these kind of disconnect between the stated intent of the ADP and the actual practice in funding and commissioning, funding, commissioning and procurement diverge substantially, and it's very difficult to operate within that. Turning to the kind of interesting models, we also saw systemic commissioners who really saw a focus on relationships, on structured collaboration, on persistent attention to the basics, trying to get the whole thing to work together as a whole. ADPs who saw themselves as innovative commissioners, so that their job was to seed funding, to explore new ideas, to explore new approaches, and then seek mainstream or matched funding along the line to make that become the new normal. And finally, we saw, and this was really interesting to me, thinking of my more general work in commissioning, the role of the radical commissioner. So this comes through particularly in the Clackmannanshire and Stirling case study. So this is the idea of commissioning as a radical act. So it's a strong focus on how you empower people within what is conceptualized as a damaging system and how commissioning can function within that. So next slide, please. Just going to check my time. Oh, I'm out of sync. That's fine. I'll quickly run through the findings and then I'll go back to the case studies. So what did we see in summary across the case studies and across the initial interviewing? So we generally found that the ADP operating context is constrained and challenging. So there's conflicting priorities, fragmented resources, and quite a substantial data lag between what people see locally on the ground and then how priorities are set nationally, which makes commissioning very challenging. The ADP role itself is intrinsically challenging and it poses challenges for commissioners. It's ambiguous in terms of power and leverage, and its accountability is kind of diffuse, which makes it very difficult for the shared accountability model set out in the ethical commissioning principles to take effect in reality. ADP commissioners, sort of in a kind of recurrent message from them was that they were trying to knit together a sort of systemic, holistic response from fragmented funding that was not sufficient often for initiatives, but also quite directed. So they felt they were kind of managing this tension between trying to be systemic, but also the drivers around them being very linear. There was substantial progress being made, and across the system, people identified this around the ethical commissioning principles of person-led and human rights-based approach. There was substantial work on full involvement of people with lived and living experience. Some respondents did not feel that had gone far enough, but everybody said that they've really seen a substantial shift in that, driven very much by the MAT standard related to engagement. Where they saw progress as constrained against the ethical commissioning principles was around the areas of financial transparency and sustainability, around outcomes-focused practice, because that's very challenging when you've got a big data lag, a very, very big data lag in the system, and therefore the knock-on effects for quality support. Everyone and all of the commissioners we spoke to were careful to say this is not about providers not providing quality support, but about how we have a system or a recovery-orientated system of care, as Perth and Kinross organised their support, that functions holistically together for people in their area. So that was kind of the nuance of the quality question. And my next slide, please. So turning briefly to the 3 case studies in the last few minutes. So I've just pulled out a quote and I'll try not to bore you with too many details. It's quite a long report, so if you don't have time, it's worth reading the executive summary and the 3 case studies because they are probably the most illustrative of the issues. So North Lanarkshire, we spoke to their ADP and their ADP coordinator. This ADP is established in an area of high need. 89% of respondents to a survey in 2020 said they thought their community had a big problem with alcohol and drug use. They're currently developing the new strategy, and they have a very structured and well-attended board and thematic subgroups that reflect the priorities for the area. The commissioning type in this area is a mixture of kind of innovative and systemic approaches with a real focus on transparency. So all data, including expenditure data, is available on a dedicated website. There's a strong focus on co-production. There is a drive towards real integration of people with lived and living experience, and indeed an ambition to go beyond the peer worker role and simply to have people in core roles within the ADP who happen to have lived experience, and they're longer term looking for fully integrated roles, which was an interesting point. There's a focus on the use of learning, even when this goes against sort of small p political preferences. So some interesting studies currently looking at the outcomes from residential rehab and what happens when people go home, and whether and how public money could be used more effectively for those populations. There's a very, as you'll see from the quote in the slide, there's a very adaptive leadership style within this ADP, and there's a real push towards relational and collaborative decision making. They are hampered by lagging data from local to national, as I discussed in the findings slides, fragmented and insufficient resourcing, particularly for emerging issues. So one of their emerging issues was alcohol use, which obviously has been deprioritised nationally, but is still a growing and constant issue for the area and for Scotland as a whole. And some very kind of quite difficult to talk about, but I think, you know, the role of the researcher is to be bold. The clinical voice very much taking priority across all of the case studies. This is really an important voice and an informed voice, but it's not the only voice. We need a whole person solution, a whole community solution. That means the balance of power and the balance of voices within the system needs to be reset. That's my next slide. So this was Perth and Kinross. This is another really interesting quote. All the ADP coordinators I spoke to were very interesting and kind of ethically driven practitioners, and you'll see that through the quotes in the case studies. Again, Perth and Kinross are at a transition point. They're closing off their old strategy. They're doing a bit of reviewing this year and building the next. The focus in this area is very much on a recovery-orientated system of care, or ROSC. So this is a model and a way of trying to knit together those fragments to offer a systemic response to people in the area. Because of the geographical aspects of the area, they're focusing very much on their post-COVID response, rebuilding in-person services and taking the best of learning from the remote working that they were engaged in over COVID, particularly given the kind of distributed nature of where services occur in Perth and Kinross, and the challenges around access in semi-rural and rural areas where people highly identify with a given area on one hand and don't want to go out with it, or on the other hand, because drug and alcohol use is so stigmatised, they would prefer to go into Perth where they won't bump into their neighbour when they're going for a support group. They very much reflect on working within a small community, the challenges on where to locate services, how you manage stigma within the population, and the strengths of existing relationships, meaning that challenge can be quite difficult within those contexts. Again, there was themes about working with power, trying to pool fragmented resources together, and a sort of foundational innovation that they're still at the consideration stage of, but I thought was worth capturing here, which was looking at a conceptual reset of ADP services. So instead of it being primarily statutory service driven with the third sector doing the rest of it, that perhaps there was merit to turning it on its head and saying third sector driven with statutory services doing the rest of it, because this was seen to reflect the actual pattern of engagement with people in the area. And my next slide, because I'm determined not to keep everybody late. And this is our final case study, Stirling and Clackmannanshire, and you will see this very radical form of commissioning coming through in this really great quote. And the kind of, again, the tension that these roles are living between trying to reduce harms in the system, reduce the harms of drug and alcohol use, and also work within that system diplomatically so that they can get the job done. Stirling and Clackmannanshire have a tiered model of support, so again, an attempt at construct a kind of holistic response to need in the area, and are engaged in a sort of variety of technical and adaptive changes. So there's a relational focus, and there's also a focus on getting the data right. You know, where are we spending the money? What are we spending it on? Is it the best use of public resources? The interesting part I wanted to highlight from this case study is that this is very much radical commissioning. The ADP coordinator in particular saw their commissioning role as to protect people from the system. And how we could reduce those harms. Again, I think this is a very difficult form of commissioning to operationalise, but one to highlight as emerging from the data. Their focus was also on improving data, evidence and feedback, for example, the use of peer inquiry to really find out where the actual current challenges and learning is and to build that in, and understanding the whole system beyond the ADP itself. So one of their key challenges is very simple and complicated in that people may not come for support because they cannot get a bus there. So how do you actually commission across those functional boundaries in a local authority area to see the whole thing as a whole? Another recurring, again, the case studies is very recurring kind of themes, but the final recurring theme was the challenges of working with a lack of positional leadership in a hierarchical system. I am aware I have 2 minutes, so can we skip on to the recommendation slide, and I will run you through these briefly. So as part of the contract with HIS, they invited us to propose some recommendations, and there's nothing researchers like better than that. We did not recommend more research though, so I feel like we should get a prize for that, because that's the bingo one that you always want to put in. So we had 3 sets of recommendations. We had recommendations to support the individual ADP coordinators now, recommendations around funding and prioritization, well, I can't say that word, and recommendations around learning and data. So for the individual ADP commissioner, these recommendations will be very familiar to people in this room. We thought just enough, so a little bit of guidance, a shared understanding, and some pictures of what ethical commissioning might look like within ADP commissioning would be of assistance. So that really just to provide people a baseline reference for their practice. We also felt that there would be merit in looking at how we align ethical commissioning principles to people's core values, because we know that values-driven action is the most powerful lever in any given system. And I talk about this quite a lot in lots of different contexts, but we saw this as instrumental here as to actually making commissioning ethical in practice, rather than making it a set of principles that are simply cited in a strategy and don't go out to work. Our funding and prioritisation recommendations were really probably the ones that are the most difficult, but along with most difficult levers are probably the ones that have a lot of effectiveness within the system. So this was really fundamentally to look at co-producing the goals in ADP commissioning between local and national partners. This is drawing together locality data, locality priorities, and the pace of change within this area with ministers and with civil servants to try and make a more shared look at what priorities are and reduce the directiveness within the environment, with the potential also of freeing up some of the income streams to be more outcomes focused and less focused on the delivery of specific, often political small p solutions to what might be quite a different problem on the ground. We also recommended a review of expenditure and effectiveness across the system. There's not a lot of money, but we maybe need to have a look at, where are we putting it? Is it working as hard as it could do? Is there something else we could do with it that's more effective? And also a significant look at place-based and human rights-based budgeting. So I don't have a lot of time to talk about this today, but Jessica Studdert from New Local is worth reading her book on her paper on place-based budgeting. This essentially is a way of seeing the money as a whole in an area and helping address some of those boundary issues we saw between, transport and transport and alcohol and drug services, or boundary issues between statutory and third sector provision. So those are two approaches that centre funding on the person and on the place that would be worth exploring in terms of a recommendation. And finally, on learning and data, we felt like, and I think this probably echoes across the system, an increase in dedicated analytical capacity in ADPs would be of great assistance in closing this data lag that we kept seeing. And that more fundamentally, and possibly you shouldn't have a particular favourite recommendation, but I'm going to be honest and say this is mine, that is there a way that we could actually build that learning orientated system that we really desperately need to replace the very directive and target driven one, in a hope of resetting the whole system towards responding more effectively to what people need locally in real time. And I can see Claire has appeared, so I'm going to stop talking. Is that right? Yeah, brilliant. But just my next slide. If you want to get in touch, that's our email addresses. Louise is the person with the PhD, so if you want to talk to her about research methods, she's the one. I'm the CEO, so I'm just full of opinions. So if you want to talk about opinions, that's my email address there. Thank you very much.
Brilliant, thank you, Dee. So the next bit that we did was we took look across both research pieces, and we thought, what are the emerging messages that are coming out that we need to use to inform what we do as Healthcare Improvement Scotland? We do a lot of work engaging directly with boards, HSCPs and alcohol and drug partnerships, and we really wanted to make sure that within our work we were able to take forward some of the practical learning around ethical commissioning. So what we did was we released a report that goes alongside the two research reports that really honed in on how we interpret those findings. So what I'm going to do is run through them with you now. They are geared towards us as an organisation, but we wanted to cover them because we think actually there's probably quite a lot of relevance for how we structure our thinking across the sector. So we broke down our analytics into 4 different categories. The first was, what did the research tell us about the way we need to invest in skills and resourcing? What did the research tell us about how we need to develop locally driven solutions? What did the research say about how we might need to challenge some of the system fundamentals? And what were the specific drug and alcohol findings, recognising that the commissioning environment for drug and alcohol services is very different than for other services such as adult social care and mental health? If we look at the investing in skills and resources part first, we had 4 areas here. So the first was that it was very clear from the evidence that unless there is a concerted effort and investment in developing the relationships required within HSCPs and between HSCPs, alcohol and drug partnerships, third sector organisations, providers, that we were unable to gain the traction required to make some of these principles work in practice. The next one was around leadership capacity, and from the research we observed some very distinct characteristics that were held within that leadership capacity that we feel really enabled them to gain traction. Leaders in this space had really good, strong commissioning knowledge. They understood the technicalities of it, they understood the ambitions of it, and they understood how to actually make things work in practice. But they also understood the ethos. They were behind what the ethical commissioning principles were. They understood how they translate into better services and support for individuals and their families and carers. They were persistent. We recognised across all of the 8 case studies that those that had made the most progress had done so with an incredible amount of persistence over a very long period of time. The next skill set was about their ability to harness that appetite for change, that they were able to bring people together behind a common goal and really understand how to motivate people to see and act on change without it being fatalistic. And the last one was that relationship management, that actually all of these examples required very nuanced and careful relationship management between a lot of disparate parties to be able to bring them together, and that sophisticated skills around those relationship management technicalities were really important. We recognised that the commissioning profession, and we talked about this slightly earlier, the continuous professional development pathways, the sense of who a commissioner is and what commissioning is, how it intersects with things like strategic planning, how it intersects with things like procurement, which are distinct but intertwined areas of expertise. And actually, in order to be able to gain greater traction across Scotland, and so that we move away from just pockets of activity into more systemic wide improvement and change, is that some development needs to happen within that commissioning profession. We need to think very explicitly about how we support and nurture that profession. And the next one was around the operationalising ethical commissioning. And actually, while we had some awareness of the principles, where things really got stuck was actually, what does that mean in practice? What are the practical operating changes I need to make in order to be able to say that I'm meaningfully adhering to person-centred, that I'm meaningfully adhering to principles around how to engage lived and living experience? The next one was around developing locally driven services. So it was really clear from the evidence that those that had made the most progress had done so by starting with local need, starting with local challenges, and starting with local assets, and really understanding what that local context was and what the local solutions would need to be in order to be able to utilise what was available nationally. So from that, we pulled out 2 key areas. The first one was where the starting point is. Those that started with a national picture or a national requirement, and we saw this in alcohol and drug commissioning particularly, was that actually there's a very strong national message here around some key measures and some key outcomes. And within commissioning, we've got a range of frameworks that support us for the procurement stage of things. So we've got a lot of things available nationally, and they're able to be utilised really effectively. But we found they were utilised most effectively when the people started with local need and worked out how to use the national elements to develop and deliver that, rather than starting with the national picture and working out how to adapt it locally. The other element was that we saw people actively building the markets that they want to see, that they were shifting away from the conventional put out an invitation to quote, wait to see who responds to it. You might have some pre-chats to try and encourage people to respond to the tender, and then you make decisions. That actually we were seeing really active steps to build a collaborative market. So we saw that around the micro providers and care at home, but also around the mental health stuff in Edinburgh with the Thrive Collective and the hubs. The next area was that it was very clear that those that were making progress in ethical commissioning were often doing so in discovering that it was working against the grain that this current system pushes us in. And that was what required a lot of persistence, that actually the ways that we go about things, the way that we're structured, and some of the fundamentals of our system move us in a particular path. And when we're trying to make changes or improvement, if they move constantly against that path, then you end up with things like staff burnout, key person risk, and sustainability issues around that impact. Within this, we felt that there were 5 areas that we thought it was time to start challenging those system fundamentals. To say, actually, unless we challenge those fundamentals, it's unreasonable to expect widespread adoption of ethical commissioning. This was around competition-driven models, that we're actually in a state now where there is far more demand than there is supply. And what does that mean for a competition-driven model? What does that mean for the way that we interpret value for money? What does it mean for the way we interpret price-quality trade-offs around this stuff? And that actually there's a lot of assumptions and a lot of processes that we've put in place over time that reinforce that competitive model that we can actually start to challenge. The next one is around some power imbalances, and we noted several types of power imbalances. One was within the commissioning organisation themselves, that commissioners' voices and service managers' voices didn't always get heard as equally as legal or procurement or finance voices, and that actually addressing those power imbalances and seeing the commissioner's voice as having a really important contribution to the discussion is really important to allow those changes to happen. But we also saw people trying to address the power imbalances that sit between the commissioned and the commissioners, and being able to be open about which bits are able to adjust that power and where the decisions are unlikely to be able to change, so that way people are going in with that same understanding and knowledge, and that we're not having misaligned expectations. We saw that the way that we structure budgets really hinders our ability to achieve some of the ethical commissioning principles around financial stability and being able to deliver care that's person-centred, that brings together budget lines that have traditionally sat really siloed. We noted challenges around very short-term funding, or funding that comes with very specific asks from national bodies around what it is for, and that the ability to bring together those budget lines and the infrastructure and the governance we have to bring those together needs to be changed if we want to see commissioning to actually support people where they are and what they need. We saw from the findings that a lot of those that were making progress were doing so by busting myths and better utilising current levers. That actually there's a lot of ways that we do things around commissioning, whereas if we can take it back, there is a lot that can be done within the current levers. And we noted that people were tackling head-on risk aversion, and that what we have around this is that we like to commission based on outputs and throughputs. Sometimes we call those outcomes and sometimes we try to move slightly towards them. But at the end of the day, that control and that oversight around commissioning is led by that risk aversion. And unless we start to challenge some of the things that drive an organisation's level of risk tolerance, then we're unlikely to see some of that transfer of power that's required to be able to have a truly collaborative approach to commissioning. And the last one is around the alcohol and drug specific findings. So there were a range of findings that were consistent across mental health, social care, social work, and drug and alcohol services. But there were specific features of the drug and alcohol market and landscape that really stood out and required a specific kind of analysis of it. So it was these things here. And Dee kind of touched on it earlier around the understanding of commissioning and ethical commissioning, but right at the heart of understanding commissioning as a concept and a role and a function and a profession within alcohol and drug services. We found that the way we fund alcohol and drug services is even more complex than the way that we fund all of the other services, that there are so many segmented pieces of funding, so much short-term funding, and that the alcohol and drug partnerships are only responsible for commissioning such a small part of what is offered to people who use drugs and alcohol, that really the funding and the way we fund is making a massive difference to whether we can achieve better commissioning practices. The commissioning strategies was another area that we have strategic plans for those alcohol and drug partnerships, but actually they didn't give us enough instruction to be able to commission off the back of it. Lived and living experience came out across the board of these pieces of research, and that how do you actually make sure that that lived and living experience is continually building in its nuance, its complexity, its meaningfulness, and the way that we actually bring people into the design and delivery of services. This stuck out even more so within the drug and alcohol context, in that this is a core tenet to some of the alcohol and drug partnerships' ambitions is around that lived and living experience. And the research noted that while it's got a lot more attention and there has been progress, the ambitions for it need to be more, and that actually those that are lived and living experience participants or representative organisations around lived and living experience are calling out for even more meaningful engagement, that they see the value in that and they see that there is willingness and buy-in and they're willing to be part of that picture. One of the elements that stuck out really heavily in drug and alcohol service commissioning is starting to challenge the way that we see outcomes and success within addiction services, and that there's a lot of variation about how we determine success. Is success complete abstinence? Is success being able to achieve other life outcomes, other life stabilities, and actually making sure that we're having really open and informed and evidence-based discussions about what do we mean by outcomes and what do we mean by success within this context is going to be really important if we're starting to use those as the fundamentals for the way that we commission. The connections between drug and alcohol commissioning and other parts of the system were brought out very heavily in this research, and in particular that connection with mental health, the connection with justice, and the connection with housing. And the last area that came out was around this data capacity. Actually, when informing commissioning decisions, what capacity around data analytics and the data available do alcohol and drug partnerships and HSCPs have in order to inform that decision? So those were the kind of key findings around how we've analysed those results. And what it has meant is that we have now looked at, and we've outlined it in our report, areas that we think we want to start doing some more of, or areas that we want to start that we haven't been working on previously. And you'll be able to kind of read those areas within that report. I'm going to pass on to Des now, who's going to run you through some polls, and then we're going to go into the question and answers.
Thanks, Claire, and thanks everybody for sharing the information from the presentations. I think it's quite evident from it that this has not been a session about saying here are all the answers to being able to do ethical commissioning. It's about saying here are the challenges, here are the examples of people who are taking forward that challenge, making a difference, but there's definitely also still a long way to go, and I think that's evident in the questions that have come out. So we'll come to them in a wee second. We're going to put up a couple of poll questions that's useful for us to understand how useful or otherwise these sessions are themselves. So we're going to put up some polls just now. They're really for us to understand, is this useful? Are people finding value?